Morning, I'll be presenting Lancet Journal, Ventilation Management and Clinical Outcomes in Invasively Ventilated Patients with COVID-19, a national multi-center observational cohort study. My moderator is Dr. Supriya ma'am. Morning, I'll be presenting Lancet Journal, Ventilation Management. Introduction. COVID-19 is caused by the highly contagious severe acute respiratory syndrome coronavirus 2, the first outbreak of which was reported in Wuhan, China at the beginning of 2019 December. Worldwide, healthcare workers have faced surges of infected patients who need hospital care and who are eventually admitted to an intensive care unit to receive invasive ventilation. Large differences in outcomes for invasively ventilated patients in COVID-19 have been reported for different countries. Example, mortality rates for which patients in China were reported to be 2 times higher than those in Italy and the USA, and even within a single country such as the UK. Several ventilatory interventions such as lung protective ventilation with a low tidal volume and a low driving pressure, high positive end expiratory pressure with recruitment maneuvers, prone positioning and extracorporeal membrane oxygenation affect case fatality in patients with acute respiratory distress syndrome. The rationale for the study: the novel coronavirus disease pandemic is rapidly expanding across the world, with over 60,000 new cases each day as of late March 2020. Healthcare workers are struggling to provide the best care for patients with proven or suspected COVID-19. Approaches for clinical care vary widely between and within countries, and new insights are acquired rapidly. This includes the way invasive ventilation is applied. Primary objective is to determine and compare invasive ventilation settings and parameters in COVID-19 patients in intensive care units of hospitals in the Netherlands. Secondary objective is to determine whether certain ventilation settings have an independent association with duration of ventilation. Hypothesis. Primary hypothesis: there is substantial variation in ventilation practices in COVID-19 patients admitted to the ICUs of hospitals in the Netherlands. Secondary hypothesis: certain ventilation settings impact duration of ventilation. Study design. It's a national multi-center service review. Study population: intensively ventilated patients with proven or suspected COVID-19. Methods: in every patient, granular ventilation settings and parameters are collected from the start of invasive ventilation for up to 72 hours. Patients will be followed up until ICU and hospital discharge and until day 90. Inclusion criteria: COVID-19 confirmed with PCR or presence of typical abnormalities on chest computed tomography. Suspected COVID-19 infection with no exclusion of diagnosis, having received invasive ventilation. Exclusion criteria is age below 18 years, already included in the same study in another hospital, having had received invasive ventilation for more than 24 hours in a non-participating hospital. Study endpoints include main ventilator settings, including tidal volume, airway pressures, oxygen fraction, and respiratory rate. Parameters such as blood gas results, use of rescue therapies, use of sedatives, vasopressors, and inotropes, development of kidney injury, ventilator-free days, and alive at day 28, duration of ICU and hospital stay, 90-day mortality. Study design and participants. ProVent COVID is an investigator-initiated national multi-center observational cohort study done at 18 ICUs in the Netherlands. The study protocol, including the statistical analysis plan, study sites were recruited through direct contact by members of the ProVent COVID steering committee. The study coordinators contacted local doctors who sought approval from their respective institutional review boards and research ethics committees. Need for individual informed consent was waived because of the observational nature of this investigation. The study coordinators and trained data collectors assisted local doctors and monitored the study accordingly to the International Conference on Harmonization of Good Clinical Practice Guidelines. Procedures. Local doctors and data collectors obtained baseline and demographic variables, including the available disease severity scores, which could be acute physiology and chronic health evaluation 2 or 4, the simplified acute physiology score 2, or sequential organ failure assessment score. Chest CT scan and chest radiography images were scored by trained data collectors for extent of lung involvement. Chest CT scans were scored as having 0%, 25%, 50%, 75%, or 100% involvement. Chest radiographs were scored as having opacities in 1, 2, 3, or 4 quadrants. ARDS severity was classified according to the current Berlin definition of ARDS. Day 0 was defined as the first calendar day that a patient received invasive ventilation in a participating ICU, irrespective of hospital or ICU admission date. For each day until day 28, hospital discharge or death, an assessment was made as to whether a patient was under invasive ventilation. A ventilation day was counted as any day that a patient was under invasive ventilation, irrespective of the duration of the invasive ventilation for that day and whether or not it was done through an orotracheal tube or a tracheostomy. Local doctors and data collectors captured detailed information regarding ventilation management up to day 3 and pulmonary and extrapulmonary events until hospital discharge up to a maximum of 28 days. In the first hour of invasive ventilation and every 8 hours thereafter, at fixed time points until day 3, ventilator settings and parameters, use of muscle paralysis, vital signs, and arterial lactate levels were captured. Once a day until day 3, SOFA score, use of sedation, use of vasopressors, cumulative fluid balance, urine output, and highest plasma creatinine were collected. Use of adjunctive treatment for refractory hypoxemia, including recruitment maneuvers, prone positioning, and ECMO was recorded until day 3. All data were entered into a password-secured internet-based electronic case report form. Before analysis, the study coordinators screened all data for potentially erroneous or incomplete recordings and verified and corrected information as appropriate with the help of local doctors and data collectors. Outcomes. The primary outcome was a combination of the main ventilator settings during the first 4 calendar days of invasive ventilation, including tidal volume, PEEP, respiratory system compliance, and driving pressure. Secondary outcomes included other ventilation variables and parameters, the use of adjunctive treatments for refractory hypoxemia and ICU complications. Patient-centered outcomes were the number of ventilator-free days at day 28, duration of ventilation, ICU and hospital length of stay, and 28-day and 90-day mortality rates. Ventilator-free days were defined as calendar days of unassisted breathing for at least 24 consecutive hours and considered the last date of successful extubation. All patients who had died by day 28 were considered to have had no ventilator-free days. These were the demographic details. Results. Between March 1 and April 1, 2020, 31 ICUs were invited to participate in Proven COVID and 18 met inclusion criteria. Of 611 individuals screened for the study, 553 patients were included. The main reason for exclusion were that they did not receive invasive ventilation or had an alternative diagnosis. All patients had ARDS according to the Berlin definition, and all patients had a positive RT-PCR for SARS-CoV-2 during their hospital stay. Patients were followed up for a median of 28.0 days. 417 patients were men and 136 were women. Median age was 67 years, and common comorbidities were hypertension and diabetes. most common ventilation mode in the first day of invasive ventilation was pressure-controlled ventilation, followed by volume-controlled ventilation. Median tidal volume was 6.3 ml per kg, predicted body weight, and 289 of 501 patients had a tidal volume of 6 ml per kg predicted body weight or less. Median PEEP was 14 centimeter H2O, driving pressure was 14 centimeter H2O, and mechanical power of ventilation was 17.7 joules per minute. Median respiratory system compliance was 31.9 ml per centimeter H2O with a near normal distribution. Median PaO2 by FiO2 was 158.8 with 46 of 541 patients having PaO2 by FiO2 less than 100. Of all variables and parameters, only blood gas analysis results and FiO2 changed over the first 2 days of ventilation. Continuous sedation and muscle paralysis were used often and for most patients for the first 4 calendar days. Vasopressors were used in most patients and there was a progressive increase in cumulative fluid balance and plasma creatinine levels over the 4 days. 1 in 5 patients developed a thromboembolic complication, mainly pulmonary embolism. Almost half of the patients acquired kidney injury and 1 in 6 needed renal replacement therapy. Reintubation was often required and tracheostomy were done in about 1 in 6 patients. Patients had a median number of ventilator-free days at day 21 of 0, and duration of ventilation in survivors was 16.5 days versus 13.5 days in all participants. Mortality increased with increasing age and decreasing PaO2 by FiO2 at the start of invasive ventilation. 186 of 530 patients had died by day 28. 214 of 495 patients died by day 90. Discussion. This report describes ventilation practice in patients with COVID-19 who received invasive ventilation during the first month of the outbreak in the Netherlands. First, it provides information on ventilation practices in these patients, which can be used to improve local practices. Second, this information could aid the understanding of potential differences in ventilatory practices and different outcomes in reports of patients with COVID-19. In this study, more than 50% of the patients received protective ventilation with a low tidal volume. The applied PEEP varied substantially and respiratory system compliance was low, with a normal distribution in all patients. Of all adjunctive treatments for refractory hypoxemia, prone positioning was used in about 50% of the patients. This study confirms the lung protective ventilation is applied well in patients with COVID-19. Example, the use of low tidal volume was more common than in previous service reviews of ventilation, and driving pressure was consistently lower than 15 centimeter H2O, even though most patients had moderate to severe ARDS. One reason why invasive ventilation settings and parameters did not vary substantially between ICUs and hospitals in the Netherlands could be that COVID-19 related ARDS allows for better use of lung protective ventilation than does ARDS due to other causes, although it has been suggested that COVID-19 ARDS is broadly similar to other forms of ARDS. Another reason could be that ICUs were well prepared using local guidelines designed especially for this outbreak. They focused on patients in the first month of the outbreak, which was at a time when little knowledge existed about the best way to ventilate these patients. It is also possible that because care for a surge of invasively ventilated patients with COVID-19 had to be provided by hospital personnel who had less experience or confidence with setting a ventilator, there was better compliance with existing guidelines for the ventilation of patients with ARDS. One notable finding is that the applied PEEP varied substantially between patients from 5 cm H2O to 20 cm H2O. This is also consistent with a study in patients with COVID-19 in Spain, although median PEEP was slightly higher in our study. It has been suggested that patients with COVID-19 might have two different phenotypes, in part based on the respiratory system compliance. However, in this study, compliance was low in nearly all patients with quite a narrow distribution. This finding is in line with results from several recently published studies showing median respiratory compliance in patients with COVID-19 of about 35 ml per centimeter H2O. In this study, adjunctive treatments were frequently used, as would be expected for patients with moderate or severe ARDS, and in line with the recent reports of COVID-19. Prone positioning was used in about 50% of the patients, higher than in other large cohorts of patients with ARDS due to other causes. It remains uncertain whether this reflects improvement in care over recent years or whether prone positioning was applied more often because of the severe hypoxemia typically present in patients with COVID-19. The data presented here could function as a basis for new hypotheses and sample size calculations for future trials of invasive ventilation in patients with COVID-19. In addition, these data could help to guide the adjustment of local practices and the interpretation of findings from other studies of COVID-19. Example, the findings of this study show that lung protective ventilation is applicable in patients with COVID-19 associated ARDS and not different from the best practice for ARDS due to other causes. Thank you.